I'm very excited about today's program. For those of you who don't know, my name's Chris Handley. I'm your GPAHU president, and on behalf of the entire GPAHU board of directors, thank you for attending today's event this morning. First and most importantly, of course, I hope everyone is staying healthy and disciplined as it pertains to fighting this pandemic. I really believe our continued discipline combined with the vaccine rollout that seems to be gaining momentum, we will be able to see the light at the end of the tunnel here very shortly. So again, I wish everyone healthy and just stay disciplined. Today's agenda, there's really three things that we were going to do today. The most important thing is to have Homestead here, and I'm really looking forward to it. But I do have I'm going to take a couple minutes to go over a couple of housekeeping items. And then, per usual protocol at these events, we're going to have a legislative update from Vicky Cagliola, of course, our GPAHU legislative chair. Vicky, being the thoughtful person that she is, she needed to record her update this morning, which we will share in a minute, because as I understand it, Vicky is helping a high-risk individual receive their COVID vaccine this morning. So, but she still found the time to give us our legislative update, and then we'll go from there. And then, of course, we'll get to our featured program, which features Homestead Smart Health Plans, cost containment innovation, the broker and employer perspective. So I think that's just so good when you have all facets. You have the purveyor of the health insurance, if you will, you have an employer perspective, and you also have the broker perspective. So I just think it's excellent. Some housekeeping items. As a reminder, there's two kinds of events in 2021. We have the monthly education events, or our marquee events, that would be like today. And then we have our GPAHU CE series events. And what's interesting is, I guess, one of the unintended consequences of COVID is that we're able to do a lot more events than we were able to do before. Just as a reminder, because you're a member and these events are for free, in January we had a CE event, which was Healthcare 2021 and Beyond. It was a panel event. It featured Scott Wham, our NAHU legislative chair through the whole country. We had Sarah Picard. We had Christy from Cigna. I mean, it was excellent. And then we all had a CE event on February 2nd with Clear Employer Services. And they talked about PEOs. On February 18th, we had a marquee event that featured Dan Tropiano, the CEO of United Healthcare. And then most recently, we had another CE event as recent as March 4th, featuring VBA, and it was a CE called Inside the Vision Health Industry. And today we've got our Homestead marquee event. So that's 5 events, and we're not even in April yet. So that's pretty good. Just so you can save the date, there are a couple events that are coming up. The first one is on April 7th. We're going to have a legislative advocacy event, if you will, and it's going to feature Marcy Buckner, NAHU's VP of Government Affairs, and our GPAHU legislative chair, Vicky Cagliola. And at this event, we're going to learn about the federal priorities that NAHU is focusing on in 2021 and beyond. Additionally, Vicky will be speaking about critical state legislative issues and the importance of our active participation in advocating for the people that we serve. Then on April 21st, we'll have another marquee event featuring Independence Blue Cross. We're going to have opening remarks from Brett Mayfield, who's IBC's VP and local market president. He's going to talk about the current state of our industry. He's going to review some leadership updates and also how we're maintaining the broker relationships in the local landscape. There'll also be speakers, Dr. Richard Snyder and Madeline Fernstorm from Quill. So we're looking forward to that. And then the last one I'll give you is on May 4th. We have another CE event featuring Cigna. This one will be about PBMs, pharmacy benefit managers, and which is obviously an important one because pharmacy is such a huge overall spend. So we've got a lot of things that we've done and a lot of things that are coming up. So without further delay, if we could go to Vicky Cagliola's legislative update, we could just move on with the show.
Good morning. In this morning's
Well, that's okay. Just like anything, this is the same thing that happens on CNN.
legislative update, I'm going to review a couple of state bills that could have an impact on our industry and on our clients. And I'm also going to go over NAHU's federal legislative priorities that they're working on for members of NAHU. So for Pennsylvania, we're in a new legislative session right now. And our legislators are in the process of getting themselves organized, getting all their committees put together. And so we're probably not going to see a lot of real movement on bills until May or June. Also, I wanted to remind everybody that we are in a split government right now for Pennsylvania. So the House and the Senate are controlled by the Republican Party. And as you know, we have a Democratic governor. So that makes it a little bit tricky for trying to pass legislation. But that's what we have right now in Pennsylvania. The bills that I have here that I'd like to talk about today, these were all introduced, but none of them have gone to vote either at the committee level or in the House or the Senate. So it's pretty early stage for all of these bills, but I wanted to make sure that I went over these so that you know what's being talked about right now that is going to have an impact possibly on our industry. So the first one is furnishing aggregate claims. This is a House bill sponsored by Dave Zimmerman out of Lancaster. And this is really a bill that would require carriers to provide aggregate claims data. And this relates to groups that are in the 51 to 99 market. So the idea here is providing these groups with some claims information that will help them better understand the performance of their plans, and then also would give them a little bit of information to help them with their renewal process and negotiations. So this one, also GPAHU members are having a meeting with Dave Zimmerman actually today to review the bill and to see what support and information we can provide so that we can help shape the way that this law is going to look like. So more on this in our next meeting. I'll be able to give you an update on how those conversations are going with that piece of legislation. The second one I wanted to mention is association health plans. And for this one, we do have both a House and a Senate bill. And these were both sponsored by individuals in Allegheny County, which is out near Pittsburgh. And so the association health plan bills are really to strengthen and expand association health plans in Pennsylvania. And if you recall, we had, under the Trump administration, an expansion of association health plans at the federal level. And at the time, the Pennsylvania Insurance Commissioner did not want to do the same in Pennsylvania. So right now, we do not have these expanded association health plans available in Pennsylvania. So these bills are really there to try and do that in the state. There were similar bills also proposed in 2019 and 2020, which did not pass. So one thing I wanted to point out here is that we do have members in the state of Pennsylvania, Commonwealth of Pennsylvania, who do believe that association health plans are good for their business. And then we also have some brokers who do not believe that association health plans would be helpful for our industry. So GPAHU has decided to not take a position on this particular issue. So we want to make sure that we're supporting all of our members regardless of what their opinion or approach is on this particular issue. The last one I wanted to mention is short-term limited duration plans. This is a House bill sponsored by Wendy Thomas out of Bucks County. And the idea behind this bill is to regulate short-term limited duration plans and protect consumers. And that would include duration and renewability restrictions, as well as some consumer disclosures. So those are the existing bills right now that we may see a little bit of activity on sometime this summer or later this year. One other thing at the state level, we do have one legislative issue I wanted to mention, and this is a co-sponsorship memo by Wendy Thomas again. And this is regarding state exchange minimum coverages. And the idea here is that if the Affordable Care Act were to be deemed unconstitutional by the Supreme Court this year, this would have some state level protections for some of the ACA types of minimum coverage requirements. I think there are around 15 or so coverages that would be required if this were to become a law. So this one is still in the co-sponsorship memo phase. So we don't have a lot of movement on this quite yet, but we're going to keep our eye on it just to see how this one goes and to see if there's any movement on this later in the year. For GPAHU, a couple of things I wanted to mention. The employer reporting relief, this is something kind of new and it relates to COVID-19. This would be compliance relief and suspension enforcement. So basically what that relates to is for employers who are required to do ACA reporting. Under normal circumstances, it's difficult, right? For any of you that are involved in this with your clients, it can be cumbersome and difficult to do. When you add a pandemic and furloughs and employees with lower hours, it becomes even more complex. So the idea here is let's give a little bit of relief to employers, not only for the reporting piece of it, but also for the penalty piece. So this is something GPAHU has been working on, and I'm hopeful that we'll see something on this in the near future. The next two items are, things that we've seen GPAHU working on for some time now. Opposition to Medicare for All and public option, of course, has been very high on their list, and it continues to be so, as well as COBRA serving as creditable coverage for Medicare. That's also something that's been worked on for some time and will be continued to be a focus for GPAHU. Lastly, a couple of market stabilizers I just wanted to mention. One is voluntary reporting, and this relates to ACA reporting for applicable large employers. And the idea here is being able to report prospectively and not doing the detailed reporting employee by employee, month by month. It's really a more simplified reporting that should at least get to the same end result, which is employers certifying what type of coverage they're offering and whether or not it's affordable and so forth. Secondly, lowering prescription drug costs. This is another area GPAHU has had a significant focus on recently. And then lastly, employer tax exclusion. The employer tax exclusion, as most of you know, is a really important part of stabilizing the market because it offers an incentive to employers to offer coverage to their employees while receiving a tax benefit. Both the employee and the employer receive that tax benefit. So this has come up over the years as sort of a money grab for legislators so that they can take the tax dollars that they could be collecting and using that to fund another initiative, some other type of bill. So if you see a project, Operation Shout, for this employer tax exclusion, I would encourage you to respond to that quickly because that's an area that sometimes crops up quickly without us really having a lot of time to discuss and respond. So lastly, I just want to put in a plug for our April legislative event. This is with Marcy Buckner, and Marcy is the GPAHU Senior VP of Government Affairs. It'll be on April 7th at 9 o'clock. And what we're going to be covering is Marcy will be explaining a lot about the inner workings of the legislative process for GPAHU. She'll be explaining how the priorities are developed and how they come up with their responses to different policies. And then we're also going to have a Q&A session for members. So this is a really great opportunity for you to ask your questions directly of Marcy and have a nice exchange, and just a way for you to better understand what GPAHU does and how the legislative process works. So thank you very much for your attention today. And this concludes my legislative update. I'm going to hand things off to the next presenter. Thank you. Have a good day.
Chris, I think you're on mute.
Oops, I apologize for that. I just wanted to thank you. So I just wanted to say that we thank Vicky for being so thoughtful. She had a prior commitment that was very important, yet she was still able to get us the information that we needed to be advocates for the people that we serve. And we look forward to everyone being on the legislative program on April 7th. So on to the main event today, featuring Homestead. So, you know, I think everyone has noticed that over the past couple of years, we've been increasing the number of presentations from our corporate partners, and we're thankful that Homestead is one of those partners at the benefactor level. And so, and additionally, why it's so important is that at the GPAHU, it's very important for us as an organization to remain objective and comprehensive in providing you, our membership, with the most current and innovative products and services available in our industry. And that brings us to today's presentation. At this point, all of you are aware of the concept of reference-based pricing. Many of you, just because I know a little bit in my day job, have quoted and have sold groups with this concept. Well, today we're going to get some information firsthand from three different perspectives. We're going to have the client perspective, the broker perspective, and the health plan perspective. And these perspectives will be presented in a panelist format, and they'll be hosted by Joe Haddock. I know Joe a little bit, but I'm getting to know him more and more, and which is great. He's been a leading sales. He's really been in leading sales efforts nationwide for these products for the past 2 or 3 years. You know, with Homestead specifically. And prior to Homestead, Joe headed up sales for one of our neighboring healthcare carriers, Geisinger, who is also an innovative carrier on their own and has their own interesting model. So Joe's very much in tune with innovation. And Joe, in addition to that, Joe's expertise really lies in strategic partnerships and product development with a heavy focus on population health management. Just a little bit more about Joe on the personal side. Joe and his wife have 3 children. And I got to tell you, they're a bunch of high achievers. His oldest son is, well, they're all kind of ending their relative phases of their formal education, which I'm sure makes Joe and his wife pretty happy. But Joe's oldest son is starting his residency at St. Luke's Hospital in Bethlehem, which is very impressive. Joe's oldest son, who's actually the middle child, just accepted a position with Pareto Captives. So, you know, I think we're all familiar with Pareto and who they are. So again, he's got 2 people in the business, but if that wasn't enough, Joe's daughter, who's their youngest child, is graduating shortly and will be a physician's assistant. So again, it's all very impressive, and we're all taking our certain positions or positions in this business to make sure that we're providing quality healthcare at an affordable price. So without further delay, I'm going to hand it over to Joe, as his experience and knowledge will help guide us through some firsthand experiences from our esteemed panel. Joe?
Thank you, Chris. Now everybody knows why I work so hard when you have that much education to fund, but I'm thrilled they're all either directly in or related to healthcare. So that's wonderful. That's a need that's going to continue for a lot of years. Appreciate the kind words. And I'd like to welcome everybody to our panel discussion this morning and thank GPAHU for having us for what I think will be a dynamic discussion revolving around the considerations and successes of reference-based pricing as an effective cost containment tool in managing health benefits. I'd like to set the stage for today's discussion. Today, we will be hearing from a leader of a large human services nonprofit organization with a diverse workforce and pressing financial concerns. And we'll hear from their broker and really the journey that they've taken together to find alternative cost containment solutions. In the past year, there's been more pressure on business owners to think outside the box, to maintain their business and ultimately thrive. And while we're all tired of hearing the phrases unprecedented times and new normal, we recognize that those who innovate forge new paths, solutions, and successes. We know there's a broad ecosystem of cost containment solutions available, and we know reference-based pricing plan is not a one-size-fits-all solution for every client, which is likely crossing the minds of brokers in attendance. So we want to reveal the thought process, the strategy, the experience, the results, or what I like to refer to as the lessons learned from an employer's perspective and a broker's perspective on the challenges and results of implementing reference-based pricing across a large and diverse population. We'll address key areas such as communication, member experience, and results. But first, let me introduce our panel. And let's see if we can, there we go. Let's start with Joe DeBella, who is Managing Director and Executive Vice President at Commerce Strong in Buffalo. Joe leads the employee benefits practice by overseeing consulting and brokerage services and leading new biz development. Joe's experienced in data analytics, underwriting, labor negotiations, wellness design, compliance, communications, strategic planning. You get the drift. He has a wealth of experience and knowledge, and you may recognize Joe as he's a frequent guest speaker for the Philadelphia Business Journal and is often quoted in regional national publications. So welcome, Joe.
Thank you.
Next, I'd like to introduce Teen Hansen-Turton, President and CEO of Wood Services, a large regional nonprofit population health management and advocacy organization. Teen has over 20 years experience in health and human services, at the executive leadership level and in consulting. She's founded and led nationally recognized organizations and trade organizations. Teen is a results-oriented leader. She's also an effective organizational change agent, and she's an advocate for health and human services policy and reform. Welcome, Teen. And finally, I'd like to introduce Bill Green, my colleague and CEO and founder of Homestead Smart Health Plans. Bill has extensive leadership background in both public and private sectors. He was previously appointed chair of the Philadelphia School Reform Commission and also served as a Philadelphia City Councilman. During his career, Bill has founded several businesses and represented Fortune 500 companies as a corporate and securities attorney. So welcome, Bill. We're going to frame the discussion today as a live case study. And I'll ask a few questions to initiate conversation in three key segments or area. In our initial discussion, we'll start with the challenges faced by Wood Services and their need to identify and fund transformation. During this session, we'll also discuss the need for change and its impact on your clients, as well as our industry. And we'll cover the organizational support needed in selecting and implementing a reference-based pricing plan. Then we'll transition to solutions. In this segment, we'll discuss the affordability of plan designs, the importance of communication to ensure employees understand the reference-based pricing plan, and the member experience, especially as it pertains to provider access and acceptance, as well as the potential for balanced billing and the resources available to the member. Lastly, we want to focus on results and discuss not just the savings achieved through RVP, but more importantly, what Wood Services was able to provide their employees as a result of their decisions and efforts. We'll also discuss the importance of choosing a partner over a vendor and how this enhanced Wood Services experience. So welcome panelists, and thank you for joining us today. As a reminder to the audience, questions can be submitted in the chat room as we go through the program, and we'll allow for some time at the end of the session for some Q&A. So with that, let's get the discussion started. A key challenge for any leader is identifying transformation within your organization and then subsequently finding a way to fund it. Team, we'll start with you. Can you please share workforce challenges that you faced when you took over as CEO of Wood Services back in 2016, and also why you identified health benefits as an opportunity for value creation within your organization?
Sure. So I'll do that. Thanks, Joe. And also thanks, Chris, for having us. Really impressive organization. Now I know more about you guys. But yeah, so I want to take you back like 5 years ago, where a little less than 5 years ago, I joined the Wood Services, which is an amazing organization. And I'll just sort of frame it so you can get an insight into my everyday life. We serve kids and adults with intellectual disabilities and developmentally challenged folks. I would say more on the severe end, so not higher functioning people with autism, more challenged populations that might also have genetic disorders, severe medical complexities, and also behavioral challenges. We serve them throughout their lifespan, which is why we call ourselves a population health management organization. Usually when people come into our system of care, they start in our schools, where we have 6 schools. We have 3 schools in Langhorne, Pennsylvania, Bucks County, and 3 schools in New Jersey. And how most clients enter our support services is through education. They either come to us and live with us because families can't really manage all their needs, daily needs, and they stay with us till they're 21. Or sometimes we have day programs where kids and youth are served go to school here, and we provide their support services, but they live with their families. How the system works is, for the intellectual disabled, up until 21, the school system funds them. At 21, they enter into the adult system where, another group, so in other words, they get Medicaid services steps in, and they are then eligible for workforce services and also group home placements. So Wood System of Care, we might have taken care of them until 21. At 21, we then place them, if family still wants to be part of our system of care, into group homes, either in Pennsylvania and New Jersey. And again, we provide all the wraparound services from sort of 24/7 care, primary care, specialty care, psychiatry care, dental care. So think of us, you guys are healthcare folks like I am. We do all the social determinants really of health, if you think about it, for this population. Our challenge is that we have a network of organizations. We serve as the parent organization with services, but under us are 6 other actually large, relatively large nonprofit organizations too, that are that make up that network of care. 2/3 of our workforce, we have a 6,000 people workforce across, the organizations, are direct care staff. So just like nursing home staff, they provide, the 24/7 care, work really hard. And the challenge that they have is, and that we have as a society, is we only pay them around $10, $11. That's what government reimburses us for their services an hour. That's not adequate enough for them. We have a huge workforce crisis that certainly was around 5 years ago when I stepped into Wood Services, but has just expanded now after the crisis, the COVID crisis. My folks, the folks that works here, are amazing employees, worked 24/7 during the COVID crisis. We did not have the luxury, neither did the leadership here, of working from home. We got to learn Zoom later on, guys, but not early on. We were all here and took care of people because they needed they had needs. Why do I say that? I say that because a few things happened to us 5 years ago. As Joe said, I stepped into an organization that's over 100 years old. We needed to do transformation. It hadn't been touched for about 10 years. We were behind on a lot of things. And when you want to do change, that's going to cost you money. It wasn't just looking at salaries. We also had to fund sort of infrastructure, et cetera. But more importantly, we were looking at also career ladders for our staff. We have, as a direct care staff, most of them come in with a high school degree, and we are in a unique opportunity where we could create career ladders within our organization. So in other words, somebody can come in with to be a direct care staff. To get them into higher paying jobs. We can help them become doctors, nurses, teachers, social workers, you name it. So we wanted to fund all of that. And the reality was when agencies like ours are paid 80 cents a dollar from government, We don't have the luxury like many healthcare colleagues to set up prices or push for a lobby for better pricing. We are reliant on government pricing that's inadequate. So we had to find the money ourselves. I am very lucky. I have a really smart executive team, and I stepped into an organization with some really folks that wanted to change. And our CFO comes more from the private sector, so it has sort of it's a very, I would say, innovative way of looking at way we fund things. And I came from a healthcare perspective, and the first thing we looked at, as you asked, Joe, was where's the money in this place? Other than the usual places of cost cutting. And that, we'd already gone through that. We really started looking at, we know the benefits area is an area where we can get more creative. And that was the journey we started with you all at Homestead. And I can come back to that, but no doubt. And I would say, we just want to sort of put a plug in here because this sector is really, challenged at this point in time. Most of our workforce today, and all of my colleagues, and many of you I know and I've seen who's here, you represent agencies like ours. Our biggest issue right now is that we have a workforce that wants to be paid $15, but we are reimbursed at $10, $11. So we have a gap we have to reach. And again, I think all of us will begin to look at our healthcare benefits because that's the only place where we think that there's a ways to give. And that's how our journey started 5 years ago and why we've been successful in some of the work we've done with you guys.
Thank you, team. Joe, let's segue to some broker perspective. You've presented on the topic change happens and need for change in healthcare. Can you share your perspective on the variety of cost containment solutions available, where RBP may fit in those solutions, and as Tina was expressing the need for innovation and change?
Sure, no, I'm happy to. And I want to echo Tina's comment and certainly appreciate the opportunity to speak with you all today. So, change does happen, and unfortunately, change in our industry, whether you're a benefit advisor, healthcare provider, TPA, change has happened slower in our industry than perhaps any other industry, whether that's transparency, whether it's engagement. And people often ask, well, why? All of the Blockbuster video stores seem to go out of business overnight, and now you have a Netflix account or some streaming service, and it literally happened in the snap of a finger. And yet in our industry, it has taken decades to get people to be more informed consumers and, using the same phrases that we have for a while. And, I've often concluded it's because healthcare is very personal and it's very emotional. So people have opined about Blockbuster went away and these streaming services happened very quickly because it was easy and convenient. And healthcare is really personal. Someone finds out they've got a cancer diagnosis, they've got a family member who's ill. The last thing they're thinking about is going to the member portal, talking to their nurse advocate, going online and looking things up. And so that personal transformation is impactful in our business. Now, hopefully technology is making things easier for people at a finger touch to be able to look and find information. So those challenges are not lost on us. But in terms of the things that are out there, we're seeing a huge emergence in what we call channel partners, firms that are very, very focused in helping people with very unique kinds of issues. So there are solutions that are emerging where a vendor of sorts sits on top of an employer's entire basket of benefits, and someone calls one number, whether it's for a dental issue, whether it's for EAP, whether it's to find a healthcare provider. And sort of those aggregator vendors are beginning to emerge in the marketplace because it is so confusing. The other we're seeing are sort of clinical channel partners. Someone needs to have surgery, and before they go through that process, they work with an advocate that helps them electively, of course, go through every single stage of the process, talks to family members, assists them about potentially avoiding opioid use from a recovery point of view, works with them on what they do when they get home. A lot of those personalized kinds of services, whether it's cancer, whether it's surgery in the MSK area, and we continue to think that those solutions will transform themselves. And then certainly, where does reference-based pricing fit in? Bill and I have often talked about this, about, the role of reference-based pricing, and it is a disruptor. And in my judgment, it is a good disruptor. It is a change. And, reference-based pricing of using, which I know Bill will comment on better than I, sort of using a different denominator to re-level set what healthcare may cost is a part of the process. We hear from employers all the time. We have the very good fortune of being the benefit consultant for Woods and work with Teen and her team all the time. And it is a constant daily conversation about what can we do to hold the line on cost without cutting benefits to our associates. And so reference-based pricing was an incredibly impactful piece of that solution. And that was a solution that Team and her leadership team brought in before we were fortunate to work with them. And that was employer driven. And that says a lot when an employer is the one that is driving that bus. So we see reference-based pricing as an emerging solution about how to sort of re-level set what a very large component of healthcare costs, how to maintain that cost, how to be transparent around that cost. And I personally see it evolving into customized networks where someone like Homestead goes into a marketplace and says, this is what our compensation arrangement will look like. And we want to build a custom micro network for employers and plan sponsors in that space. And that's sort of the emergence that we are seeing. But back to the beginning, this notion of disruption in healthcare, I happen to think reference-based pricing and a lot of the other solutions are warranted disruptors, not in a negative way, but in a way that is forcing the conversation about what healthcare costs.
That's great. Thank you, Joe. And as we get in this discussion, there's going to be some opportunity for the panel to elaborate on some of those customized networks and what we've seen from in the industry. You mentioned channel partners, but this assistance for members, if anything, over the last 5 years, 10 years, we've really seen the industry rise up in that capability, which helps everybody in the long run. So that's great. You mentioned RBP, probably a good time to enter RBP, reference-based pricing. Bill, can you just provide for the audience high-level description on how RBP works and how you identify the value it can bring to an organization such as Woods?
Sure. Good morning, everyone. Thank you for joining us, and thank you, Chris and GPAHU for organizing this event. I want to thank our fellow panelists for joining us as well. Teen and Joe, we appreciate you getting up, into your offices. I don't know if it's early or not, but you arrive at your office. But thank you very much for joining us as well. So at a very base, simple level, RBR vendors share one thing. They basically take a reference price. That's what the R stands for, reference-based repricing. And the reference price most RBR vendors use, and the vendors that you're all familiar with as brokers use, is Medicare. And then people pay a different percentage on top of Medicare. So instead of having a contract with a hospital based on the hospital's charge master, which is 650% of Medicare in New Jersey and 550% of Medicare in Pennsylvania, we, as Joe said, use a denominator instead of a numerator in order to determine what a fair reimbursement is to a provider. And so we, instead of having contracts with facilities, we pay a fair and transparent price of 125%, 140%, 150% of Medicare. And, this will be true across the industry. 97, 98% of the time, that bill gets paid to a hospital facility and is accepted. And then also most RBR vendors also have a physician network. So you're really only repricing facilities, which are a much smaller subset of claims. We use PHCS physician only, which has about 900,000 doctors nationwide. So the front door is completely open. Our instance of reference-based repricing is a little bit different than everybody else in the industry in that, in addition to doing that repricing, we also own a TPA called Index Corporation in Lyndhurst, New Jersey. And we have our own stop loss company, Homestead Insurance Company, which we acquired in 2015. And we use a fronting carrier of US Fire, so it's on A-rated paper. But we're the only RBR company that takes the risk and guarantees the result by providing specific and aggregate stop loss ourselves. And also we have all three legs of the stool. So it is a completely integrated solution, and it's not one TPA with a different stop loss provider with a different RBR vendor, so that the buck stops with us. We are the one call you have to make when there's something you need on the plan.
Great, thank you, Bill. It's a great level set and a good lead in as I look to teen, because another challenge that leaders face is gaining the organizational support to lead and implement change, especially as it pertains to RBP. What we hear is CFOs get it, and then everything lands on the shoulders of human resources. So, Teen, what apprehensions did you encounter when you're recommending RBP or selecting with your leadership team, and how'd you address them?
Sure, and I think you said something important here. So human resources are risk adverse by nature, and we want them to be that. We want them to do a thorough job. So I've always said to my colleagues, when you try something new and try to innovate, and you really it needs to be driven by the senior leadership. So in our case, it was myself, a CEO, and the CFO, bringing in human resources and really saying, we're going to try something new. We knew that, roughly we would get, based on, we'd done a lot of research, we would at least get 20% savings. That was a huge need for us. We knew we needed it. We brought our executive team in and said, we're going to try this. First of all, coming from healthcare, I think there was a level of trust from at least my team's perspective that probably this leadership team that is new and know what they're doing. And we also said that the risk falls on us. If this doesn't work out, in other words, HR does not, our wonderful HR team does not get in trouble. It really lands on the shoulders of myself as a leader. So part of it was we were looking for, and this becomes important, I would say that Bill calls it a three-legged stool. We were looking for really a partner in doing this. And there are, there's not a lot of companies, but there are several companies. And we really looked at, if we're going to do something new, our workforce is, I would say, that most of them are unskilled, not educated. So we knew we had to hold people's hands. So we looked at, we looked for a company that happens to be you guys at Homestead. You have it all under you. We were looking for somebody where we could drive and be a real partner and actually make changes to our adoption of a reference-based pricing plan as we were executing it. So it really started with, first of all, we started with what I call toe dipping with a slides offering. We fully knew that we were going to eventually replace it across the board with our affiliates, but we wanted to test it out. And part of that was for the leadership. Actually, the whole C-suite stepped out and said, we have all joined this plan because, again, you want to show your workforce when you introduce something new that you're willing to be the guinea pig, whatever you may call it. We also, we're very transparent, and this is where the communications come in. We work very closely with Homestead and with HR because we knew there was going to be somewhat of a burden on HR. So, and we have a strong communications team. So we rolled out a whole education and I would say a communications campaign around it. And part of that campaign was to say, we're going to try something new. All the investments, so the 20%, which is a lot of money for a place like Woods that has a $340 million collective budget, that means a lot will be reinvested into you, workforce, and our education programs and all the things we have promised you. So the promise for the workforce was that this would be a cost saving that would be invested in them. That was part of our communication. Again, seeing, I think the leadership was part of it, was very key. And another important piece of the communications was that, the two issues you mentioned first, Joe, is the big, boo-boo out there is all balanced bills. Well, I've had, traditional healthcare plans most of my life. You can get balanced bills anywhere. And I remember having to deal with balanced bills with a traditional plan and got no support whatsoever. So we made it very clear to Homestead is that any balance bill issues, you need to be front and center and take care of it. We do not want to scare our workforce. And we also said to the workforce, when this happens, and this is when you get something that looks like maybe a weird bill or a letter, you right away get that to Homestead. They have an app, which is great, or you give it to HR, and then we will take care of it and take if there's any lawyers involved, etc. You will not, get harmed, and nothing will negatively impact you. So that was always the promise from the get-go, that there was really no risk to our staff. The other thing we did, and this is why we liked the Homestead model, was many of you said it, Joe, you said it. I mean, we all like our, physicians, in my case, nurse practitioners, et cetera. We, especially as women, we love our OBGYNs, don't touch them. We want to go to them. Many of them have, helped us give birth to our babies, et cetera. So we got strong connections, probably more strong connections to that primary care, that front door that Bill mentioned. That's where the stronger connection is in healthcare. You want to go to your doctors, your nurse practitioners, your OBGYNs, maybe less so on the specialty care, because that comes on a more as needed basis when things happen in your life. So what Homestead did, what we liked, is that they were proactive. We very early on we figured out who are the various providers that are our staff uses, so we could be proactive and tell them we are going to do this new plan. And Homestead reached out, so there wasn't this. Many of them were on the network that Homestead's part of, but if not, they were introduced prior to, and that gave a level set, I think, of comfort for our staff. We also did another thing and this was for more specialty care, and this is where networks come in. Not all healthcare is created equal. So we spend a lot of time, especially for more, if people, let's say, unfortunately got cancer or something else, we spend some time, and this is where Joe's comment come in, is that there are really good health systems out there, and we're very lucky that Homestead has a partnership, a strong partnership with Penn, the Penn system of care. So we use it to educate our staff, saying that there are quality providers out there, those facilities that do a better job than others. And we also use that to say, we're going to create an important healthcare experience for you, where you're going to get, really excellent care. So it was all of that stuff wrapped into one that really made the difference. And I think all of that reassured our human resources department that they were not alone, and when there were questions, et cetera, the whole leadership team was part of it. And so was Homestead. Homestead was front and center in helping us out with that. The key piece for us was, I think that, Bill said it, we like the fact that there's a stop loss here, but really the legal representation was huge for us. And especially when we started talking this 5 years ago with Homestead, I'm not sure others had it. That was key for us. We did not want to have to engage lawyers, et cetera. And that was a promise that if there were issues, and there really haven't been issues, which is great, we would have, and they would take the risk and work with us and our staff to deal with any potential negative legal issues related to a balance bill.
Thank you, team. Great response. A lot of nuggets in there, and we're gonna get at some of those too, to deeper dive. So there's a lot of great things in communication. We opened up earlier, or I did, and said, it's not a one size fits all. And I think your explanation really exemplifies that from another perspective, another lens, to say it's not a standard off the shelf plan, right? It's adapting, it's finding solutions, it's customized, it's owned. And that kind of leads into acceptance and uptake with RVP. Joe, before we transition to solutions,
hey, Joe,
yep.
I just want to jump in here. Oh, I'm so sorry. I just want to jump in here real quick and say that honestly, as an organization, I think our first year working with Woods was 2017. We were a fairly new company, although we had the TPA since 2011. We really started in RBR in 2016, and Woods management and their HR department have really held us accountable. And frankly, at least every quarter or every 6 months, we sit down with them and they tell us how we can improve. And that has really helped us grow as an organization and made us a lot better. And it's a practice that we've followed with our other large clients that I just want to thank Woods and their team for, helping us continue to innovate and move the ball forward and provide better service every year based on their feedback. Sometimes I would call it feedback. Sometimes I would call it something a bit stronger. But we always seem to get there, and I just want to thank Woods for that.
Yeah, and that speaks volumes to the notion of partner, not a vendor. And again, when you look at the innovation that's occurring in the industry and some of the cost-saving solutions, those some are adaptable, and RVP solutions in general can adapt to specific client needs and really form those partnerships. So that's great. We will transition, but Joe, just for value of the audience, there are a lot of brokers in attendance. Teen and Woods are unique. You've got a change agent with experience and background in healthcare. So just in general, how do you, is there anything, advice or guidance when you look at clients and trying to determine if RVP is right for them?
Yeah, I
We
mean,
do. Oh, go ahead, Teen.
yeah, no, go ahead. No, go ahead. Because Joe, you see more of them. So yeah, go ahead.
I was going to say, if this is going to sound like I'm being overly patronizing the team, but if every client had a CEO at the table who gets it and had that focus, that would be a big plus. And we all know those that do what brokers and consultants do for a living, that isn't always the case. But a common attribute is that you need senior leadership involved. You have to have C-suite involved in the decision. If you're going to go reference-based, they need to understand. They need to ask all of the questions. You need to be entirely transparent about what to expect. And you just need to tell them all of the things that will be different about it. And if you do not have that senior leadership, CEO, CFO at the table, it's going to be a challenge. It shouldn't be, but it will be, because it is different than the conventional kind of plan. The other just general characteristic, and this may sound overly simplistic, but the customer has to have an appetite to be self-insured, right? Not every company has the appetite, the bandwidth, the risk tolerance to enter into a self-funded plan. So, that's another issue, that you need to understand all of the benefits of being self-insured, of which are voluminous. And so getting through that notion of you're going to have a self-funded plan, and then you're going to buy and consume healthcare differently than what you've been used to, and making sure you've got the right leadership buy-in. If you don't have that, it won't succeed. And Teen, you could probably add to that, from your perspective, how you've had your whole senior leadership team involved in this.
Yeah, I mean, so and that's key is usually what drives, and that's why I sort of, the timing is nice. We were in a unique situation 5 years ago stepping in, but all of us are always unique when we take over leadership positions. Now, especially our sector, many of you represent our sector, your human services sector. Unlike retail, unlike healthcare, we can't set up pricing. So, and the demand outside, we are, our competition now are the Amazons of the world that are paying 15 target. Now they don't pay the benefits, so don't get me started on that. But it doesn't matter. People want, they're looking at $13, $15 an hour. So I think you'll find pressure, and I hear that from my colleagues. I'm under pressure right now, to even find more money so we can increase our hourly salaries again for our staff. I mean, I think you're going to hear that, and the pandemic has just, become, it's just helped, sort of, I think, show us that some folks are making more than others, and people want, make, close to a living wage, and it's not $7 or whatever the minimum wage is in Pennsylvania where we are. It is closer to 15, and you got to find the money somewhere. And that's where I think the broker come in. I mean, I think that brokers and consultants need to also play a little bit more, get the leadership, to Joe's point. If the leadership is not involved, maybe get the leadership involved, so and also explain that, there's very little risk in trying a reference-based pricing plan from my perspective. But there is a little bit more hand-holding up front, but now everybody at our company understands how it works. And they should try it at least and see those savings that we saw.
That's great. And to the audience, thank you. Some questions are coming in. We will leave some time towards the end to field a few, so I appreciate that. Keep them coming. Teen, you mentioned benefits, which is great. That's a really good segue into solutions. Because what I would say is a significant portion of the lower and middle classes are becoming functionally uninsured. They can't afford to receive treatment when faced with higher deductibles or co-insurance. So as you talk about competing, and they want benefits they could afford to use. So describe how you were able to address that challenge and the reaction you got from your employees.
Yeah, so we were able, because we moved to a reference-based pricing plan with Homestead, we were able to offer essentially a no deductible plan. So in other words, there's no money taken out of that paycheck. That is huge when you're making, $10 to $15 an hour, because that's money you're saving. Most of our colleagues that have not moved to where we moved to have not been able to do that, because so they also look to benefits for savings. So more of that cost falls, as you said, Joe, on the employer, employee going to another company. So in other words, they might have, $25, $50, $100, $150 taken out every pay of the paycheck. So we've been able to create some very competitive and healthcare benefits for all of our staff, which they like and have become accustomed to. And I would say that was a game changer as well. I think the first year when we started, the employees, we saved them $1,700 just our employees per employee that they were not paying going with reference-based pricing. That was money in their pockets, guys, and that's a game changer. If you deal with professionals, that may not be as important to them, but all of us like money, I think. But it means a lot to a family of 4 that might be making, $50,000 a year, having that extra $1,700 in their paycheck. So that was key. And then I would say that, what has also, I mean, it's wrong true, is that we've saved overall, 20%. And we were able to, after that year where we had tried things out, and we were able to, I think, get it right with Homestead, and we understood it, and we understood the process and how to deal if there were issues. I think one of the questions from the panelists were, who actually takes the responsibility. Woods and Homestead takes the responsibility. We've said from day one, nobody's going to pay a bill, and if if they get bills from collection agencies, Homestead engages a lawyer that stops that, and thankfully there are rights for people. So all of that stuff is kind of automatic, and that's built into the Homestead's plan, and that's been helpful to us. And that's, again, was what we were looking for. But money, direct money in the pocket is what makes the difference, and that we've been able to continue to do that. And also now we rolled it out this year to our affiliate agencies, so throughout the whole corporation.
That's great. And Joe, we know Teen is unique, special in a lot of ways, and just her thought process and approach. But this really does hit upon a pretty good point. And, whether or not we've hit a tipping point in healthcare about members affording plans. And I know Common Strong Bucklew has a wide range of different clients, but I guess just your perspective is that a more commonality with RBP to say, hey, if there is savings, what can we do from not just the employer's perspective, but give back to employee, and then subsequently enhance the launch of a program? Is that something you see as possibility or experiencing?
It is, and we do see it. So for those clients where reference-based pricing is a match, we have seen them be able to hold the line on contributions, on passing along increases, on potentially reinvesting in other benefits, life, disability, things that are important to people that don't often get the attention, but in the suite of coverages that employees are looking for, being able to reinvest more dollars in some of those categories is something else that we have seen. And so it sort of goes back, Joe, to your question about employer buy-in and what they need to do.
Yeah.
They also need to be transparent with their employees, right? That they're moving to a different kind of experience around how they're going to engage healthcare, and why it's important for the employee to know, and how, if it's successful, and we've seen it be successful, how those savings will be passed along. So clearly we've seen employers emulate a lot of what Woods has done by being able to hold the line on contributions and making investments back in other kinds of plans.
That's actually great. Yeah, great comments, great advice. I'm going to segue to communication, because that's exactly what you're talking about, right? As transparent, there's a win in a lot of different areas. Before I do, I'll get Bill's perspective real quick, because we've talked a lot about benefits and the change, and bending that curve from where it's been going and continue to project back to affordability. How about the providers side of this? So when you think about benefits in some of these higher deductible amounts, what have hospitals and facilities experienced when trying to collect some of the ever increasing deductible and coinsurance they're seeing?
Yeah, so hospitals collect on average about 20%, 19 to 21% of patient responsibility. And so, the high deductible plans, especially that are out there, and most RBP plans are not high deductible plans. In fact, we don't recommend that, and the savings are still there. So we're able to work out arrangements with providers, and for example, in each market we go in, as Joe mentioned early on, we try, once we have enough traction there, generally we'll try to pick a provider so that there is one place where people know that they can go if another facility or provider wouldn't want to take the plan. In this market, we have a direct contract for our members and employer groups with the hospital system of the University of Pennsylvania. And we're close to a contract with a major hospital system in South Jersey. And so so basically we get a lower rate with the provider in exchange for the employer, the employee portion have a very low or no patient responsibility to pay. And that's one aspect. I don't know if that's exactly what you were looking for.
Yeah, it's perfect. Absolutely. That, the trend that we see has a rippling effect in a lot of areas, and bending it back can help the provider side as well. So thank you. It's perfect. I want to transition to communication. It is important part of any health benefits plan, especially RBP is what we've heard from the panelists. One of the common pushbacks you'll hear is members won't understand their new RBP plan. We started to address this, and I think it's worthy of just the coming back to it to make sure we've communicated key points and again, providing some guidance to the audience. With the workforce challenges that Woods had, and from a diversity standpoint, level of education standpoint, pretty significant. How are you able to ensure that they understood their new benefits plan? And we spoke about this earlier, but I guess the reiteration, how important was that why the change was being made?
Yeah, and so a lot of this is, I mean, we got, and I've shared that with other folks around the country that are looking at, a lot of organizations are looking at this. It's not rocket science, so it's putting strong communications around it. What's different about it? It's actually an open network. You don't lose. I mean, so there's sort of there's a little bit of a misnomer out there that you can't go to certain places. On the contrary, this is a completely open network with the risk that one potentially hospital might not see you or see you. So, which is why I think the approach at Homestead is taking that anchor hospital in each of the communities is key. Penn happens to be the one in the Philadelphia region, which is the best. And great fan of them and what they stand for. However, I would say key for us was, what we also had to do, we were early on, we were like the early adopters. So we actually used our little card, which is the typical healthcare card we'll carry, to actually put some messages in there. That's one of the things that Bill said we evolved together, because staff came back to us and said, well, my front desk person doesn't know what this is. So we learned from and we actually became sort of a learning lab very quickly. So if you look at my, my card from Homestead, it's brilliant. It has everything on there you want to know. It's kind of like, a little card with both sides. So rather than having the staff sort of having to explain it, and this was the feedback, they just hand that card up. All the key information is on there for that front desk person not to be confused. And that has eliminated any kind of questions when again, our front desk people and our healthcare people are used to seeing the logos. We love that in this country. So this is a new logo that's being introduced to the community. So again, that card became key as a key communicator. And then ongoing, I think just talking, being very transparent about still the savings we've gotten, what has that allowed you to do with the workforce? For us, has been important for bonuses, et cetera. So every year we put a benefit statement together for our staff that shows them how much money we're actually paying for them in benefits, how much extra money they have in their pockets because we have a Homestead plan. So we're strategic and always being very transparent with our workforce to tell them this is what you get out of Woods and being part of it. So it is about transparency. It's about having a partner that's willing to customize some of those messages, et cetera. And also a consultant like Connor Strong that does the same. It's really a partnership with all the three of us. I think we've done a great job educating our team, but that little card becomes important and it's been kind of, ever since we created what I call the final card we've done where everything is on there, a lot of sort of those questions have been eliminated if people did show up certain places and they weren't familiar with Homestead. But again, all that came from our input from staff and Homestead's and Connor Strong's ability to quickly adapt and make changes so we could, we could be responsive to a workforce when they had concerns. Balance bills came up a lot. I mean, this is part of the communication. I think that this is important because I'm seeing it. We take full responsibility. That was the one thing I said from day one. If there is any issues on balance bills, et cetera, there is no risk to our staff. There has been some collection agencies in a few places. Homestead with their legal team steps in and stops that. And again, if there's been balance bills, we've negotiated some of them. And again, that burdens it on us. There is no risk to the staff, and that's key there. And I think that's to be successful. The organization has to take that on. I have myself experience, I mentioned that before, dealing with balance bills. It is a customer service approach when there's balance bill issues. Homestead is very explanatory to our staff. They hold their hands, etc. That's key as well to make this successful.
Yeah.
Thank you, team. Yeah, good, Bill. I said you hit the last segment, or the topic of the segment, balance bills, and I would just open it up to Bill or Joe.
So what I wanted to add is actually this is the card, and the bottom of this card, basically this card is much clearer because Woods communications people and others sat down with us and said, okay, we need to very simply tell the provider on the front of the card exactly what this is. And so right at the bottom it says, so the member can read it and the provider can tell providers health plan uses PHCS practitioner only and claim watcher. Because a lot of front desks don't see a lot of PHCS cards, even though most front desks, receptionists or people in doctor's offices are signed up with PHCS. And it really has simplified things. And the other innovation that came from working with Woods in terms of communications was literally when we had a new Woods member or at open enrollment for the affiliates of Woods that came on in the past couple of years, we did something that we didn't do when Woods first came on, which was call each member at least 3 times to re-explain, even though they've been through open enrollment, how this program works, that it is open, it's not like a network, they're not restricted to PHCS, they can go anywhere they want, any provider, and re-explain to them what to do if they get bills or mail that they're worried could be a bill, send it to us, etc. And so right when the card goes out, we also call each member at least 3 times, and we connect with maybe 50% of them, but they're all talking amongst each other because it is a new health plan. And so we try to immediately open the door and introduce ourselves and let them know we're there for them.
Joe, one quick anecdote to share with the group.
Sure.
So here's from an insurance perspective. Imagine you're about to go buy a new car. And the first thing is you call your Allstate agent and say, which car dealership am I allowed to go buy a car from? It's absurd. That's generally how we have been programmed around where to choose healthcare. And so when we've communicated with people, we've said, just picture that. You want to go buy a car, but you first have to call Geico or Allstate or Farmers and find out who's in my car network. It's the most absurd thing. So, and that's not a criticism of the health plans and how they operate. That's just the way we've been programmed. And so from a reference-based pricing perspective, it's certainly all the things we've talked about that I won't repeat because Teen and Bill described them so eloquently, but it is a re-mindset of where do you need to go to get your healthcare? What's the best quality performing provider? Let that be your focus. I need to get knee replacement surgery. Which hospital has the best quality outcomes for knee replacement surgery and electively? Obviously, in an emergency, it's a different situation, but go about it around best experience, best quality, best outcome, and then a reference-based pricing solution is going to handle sort of that economic transaction with the provider. Can there be certain hiccups that you need to be conscious of? Yes. Do we see a lot of that? No, we really don't. And Woods is a very large employer, and the number of times that things happen is no greater than when the common member goes out of network in their current health plan and gets a gigantic balance bill and they're upset about it. So we really, we focus on the reprogramming of the mindset as a way to help communicate and educate.
And just one thing for here from a hospital network, because some of you guys, work with hospitals, we are able to pay faster. We're very familiar with how many times you have to send a bill in, and it gets whatever, things are not quite right, and 6 months later it gets paid. One of the commitments of reference-based pricing with the hospital is also fast payment, which is huge on the cash flow side. So that's, I think, is a benefit to a health system, which is what I always say to my health system colleagues. I have lots of colleagues that are CEOs of hospitals. We pay fast because, again, And that's part of the discount. So you don't have all the administration, you know. In many ways, this is the most American way of doing it. Let's just pay it, you know, and get, you know, take some of that red tape out of healthcare that also costs money.
Hey, Joe, I'm sensitive to people's time. I think
Yep.
we're running a little bit over. Maybe I
Yep.
think we just cover a lot of the results during the course of this, and maybe we should go to Q&A so we can.
I'm going to peek, and audience, forgive me because there's a lot in there. I'm going to peek at the questions, and exactly right. I want to be cognizant of time. If Teen could, just as a last tee up, as we talk about results, or Joe, just speak to validate. Did RVP generate the savings of what you expected, and then what you did to use some of those savings to give back in regards to employee engagement and well-being. And I will peek at a few questions to make sure we're getting all of them. So Tina, if you could just do that.
Yes, so it's absolutely across the board. We have had a north of 20% savings. We were able to pay, you know, higher, hourly salaries, but more importantly, we invested a lot of our funding into these career ladders I mentioned. Right now we have 350 people that are in educational cohorts that are either getting their associate degrees, their bachelor's degrees, or master's degrees, and many of them have already gotten promotions within the organizations because we've now been at it for 3 years. So absolutely, and so the proof is in the pudding, and we remind our staff that was the sort of the theory of change, that we would, do that, but we would invest in them, and they've seen that investment come true already.
Great. A few questions coming in. One is probably a quicker response for Bill. Does Homestead only work with one reinsurer, or do they use preferred carriers? Can the consultant bring in any other reinsurers? If you could address that.
Yeah, sure. Yes, we do offer all the solutions I mentioned, 3 legs of the stool, but we do work with many. About 50% of our groups do not use our insurance because of relationships brokers and others have with other carriers. So absolutely, we'll work with anybody. We do have
Great.
some language required in our policy, so the carrier has to be willing to accept that, and I think that's true of most RBR vendors. We want to leave it open so that we don't have to rush to pay claims at the end of the term. But other than that, we'll work with anybody.
Great. We touched upon this, but I think it's important because we got as a question to make sure we answer it definitively. And so this question was for Teen. For those claims where a member received a large balance bill, who holds the liability of that balance? Do you, the employer, hold the liability, or is it on the member? And then what happens when the member receives a collection notice?
Yeah, so again, it's on the employer, it's on us. So that was the commitment, and this should be the any company. It's streamlined. So we've trained our staff. That was part of the education too. You get something, give it to us, and give it to Homestead. Homestead has an app, so they can send it in. Many times they like to go to the HR department, and the HR department just sends it directly to Homestead, and the whole process starts. We get, if need be, we get, they get a lawyer involved, etc. Lots of communication with the staff, and the harassment, as I call it, sort of stops, from that perspective on.
Great. We're getting great questions, guys, and this is perfect. We can answer them in this kind of rapid fire format. Another one, has Woods employees experienced issues where certain facilities turn away their members due to the health plan? How are you and Homestead handling these situations?
So yes, so there, we have one hospital that does not, does not want to take Homestead. But that's a beautiful. It happens to be not a hospital that actually has that much high quality scores, which is another question in terms of, yes, we do look at quality ratings, etc. So we use that as an educational moment, and we've done that to direct people to other places. Homestead's concierge services is second to none. They will help our member. It's like, being, one of those fancy concierge services that most folks with a lot of money are able to get. Our staff gets that, and Homestead will help our staff find a quality provider. So I would say some of that, if there's negativity, it's interestingly often from not the highest quality, facilities. So we use that as an educational moment. I think over time, everybody will take, reference-based pricing plans. They'll have a choice. I think otherwise, consumers will probably drive them out of business, because I think people are pretty smart now about what quality hospitals are, and all that stuff.
Great. Let's take one more. Probably to Bill. What percentage of claims are an issue where a hospital system will not accept RBP reimbursement? And when, and if this happens, is there an offer made to close the issue?
Yeah, so typically the hospital will pre-cert, we will approve, and the procedure will happen, and then roughly 2% of the time that results in a balanced bill. There are the very rare exceptions where a hospital will flag something, and as Teen mentioned, we do have one hospital, one single hospital, not a system, that is in the region that before they will do a procedure, they request us to have a single case agreement, and then we'll negotiate that with the provider. If the employee really kind of insists on going there, we will also offer an alternative to the employee, like for example, in this region, Penn, a Penn medicine doctor and system, and often we can successfully redirect the member to a higher performing hospital in terms of readmission rates, hospital-borne illness and stuff, and as well as what the reputational scores of the doctors are, what they would consider a better doctor for the procedure
Great.
that they're trying to get.
And along those lines, another one that just said, I'll read the last part of it. Is there a difference between, when we're talking about balanced bills, between advocacy and defense?
Sure. Advocacy can be upfront. For example, negotiating a single patient agreement for somebody, or it can be after the fact when we're negotiating with the provider and trying to work out the balance bill before it gets complicated. Out of if you take a sample of 1 million claims, we had about 16,000, almost 17,000 balance bills, and then we had roughly 450 second balance bills. So there's a lot that's happening in between. An initial inquiry. There's a lot of advocacy happening before it gets to a level where we'd have to get lawyers involved.
That's great. Wonderful. And any questions that came in or come in subsequently afterwards, we will gladly address post.
And Joe, I just Joe, if I can just add sort of something that I think Joe from Connor Strong said early on is that, I'm a big proponent of disruptive innovation, and Clayton Christensen, his models, et cetera. But I think, there's a lot on both there, you've got your consultants, brokers on that are listening in, but also traditional health plans. I mean, I think that there's nothing better in the world than to disrupt yourself in the process. I think our healthcare is our consumers. I think this generation, the generation that are become before us, the Xers, I'm an Xer, it's going to be very savvy. They're looking for something very different. And I think that sometimes it's healthy to reinvent yourself. So I strongly would encourage, and I know that, they do that, with Homestead, but others do that as well, partner up with reference-based pricing plans, rather than seeing it as a force against the traditional plans. Healthcare is too expensive, it's too costly in this country. Employers cannot afford it. That's just the bottom line. So rather than fight it, figure out how to incorporate it and be a partner. And I think that's sort of my sort of take-home messages, because I think we all need to be part of the solution in this country with a healthcare system that continues to bankrupt us. And right now in our sector, I'm still trying to figure out how I can afford to pay $15 versus our $13 per staff. So and again, so I'm going to continue to look to the healthcare side to get that cost, because I don't know where else I'm going to get it.
Yeah, I think that's a great comment. We talked throughout our discussion about, one size might not fit all. We thought about it from the other lens about how being adaptive, reactive really fits the need of what employers are looking for. I think you really summed it up well in that positive disruption is good for all and will make all of us better. So what we see and the successes that we've seen, how can you translate that into other things, other partnerships? How does it morph? What does 2.0, 3.0 look like? And as Joe alluded to, there's so much opportunity for intervention in us to continue to evolve and get better, that innovation will help keep pushing and driving that. So great comments.
Yeah,
I
just want to quickly say that, for most employers that we deal with, especially in the behavioral health, social services sector, the second largest expense of an employer is their healthcare cost. their healthcare benefits. And so it is a place where there's significant opportunity looking at different innovative models. So with that, I just want to thank GPAHU and Chris for putting us together. And then
Yeah.
I know, Joe, you have some things to say.
I'll just reiterate that. Great discussion. I want to thank our panelists for sharing your time and insights. And I too, again, want to thank GPHU for the opportunity to host this discussion. And a lot of great conversation came out of it. I hope the audience found it informative. GPHU will provide contact information for the panelists. And honestly, we look forward to continuing this discussion, as Tina alluded to. Let's continue it. We look forward to your support in providing innovative cost containment solutions, positive disruption for clients, and continue to advocate for change within our industry. So thank you. And we will turn the program back over to Chris.
Thank you very much, guys. Very impressive. Teen, I have to say, and I'm sure you get this a lot, and I'm not trying to be patronizing either, but Wood Services, wow, what an amazing mission that you guys have been in business 100 years. You got a 6,000 plus workforce, and you're trying to serve 4,000 people with special needs. And, you know, it's for all of us who are benefit consultants here on the program, like you start to realize too, that it's not just about the benefits. Like the organization has a real challenge. Like her job's not easy. We've got here's what I wrote down. I got $10, the equivalent of $10 per person coming in for funding, and employees that want to make $15 an hour. So you're right. Where's the money come from? In other words, your job's hard. So then as broker consultants, and you look at somebody like Joe DeBella, Connor Strong, I mean, his reputation precedes itself. And you have to work with someone who understands how the health benefits and the benefit program fits in to the whole puzzle, which again takes a comprehensive approach to it. It takes time. And again, I would just say then the third piece of this, when you look at Bill Green and Joe Haddock, you know, whenever we work with people, we want to make sure that we're surrounding ourselves with people who are transparent and comprehensive. And again, they use things like lessons learned and that type of thing. You know, those are the types of people that I would say that if you gravitate toward, you'll end up being more successful. So I really appreciated this program very much. I think everybody got a lot out of it. I hope we see everyone on April 7th for our legislative meeting and our legislative program. And I wish everyone a healthy and happy rest of the week and weekend. Thank you.
Thank you, everybody.
Thanks, everyone.